Yeah, it's kind of funny because all of us there are predominantly imagers as opposed to
You're going to introduce us?
The second and fourth speakers, and you introduce the first.
Oh,
I didn't want to
okay,
go down.
sure.
So mainly
Oh, because I'm a co-chair. Am I a co-chair? I'm not listed as a co-chair, so I wasn't sure.
You're not?
No, just you. What?
I don't know why.
Oh, I see.
Which just referring to? I apologize. I think
No, well, it's literally not properly out yet. We
Daughter's birthday
just put
month.
together a review on how to image cardiac amyloidosis jack imaging.
How old's your daughter?
30.
Yeah, because Shamila had authored the consensus.
And she gets birthday muffins.
Yeah, so then
That's
she
lovely.
We were in Israel. She lives in Israel. We were
Oh,
there.
okay.
We just came back yesterday. And my wife got up early and baked her muffins on her birthday.
Oh, that's nice.
She was staying with us with her 4 kids. All right. Shall we go? You have your own microphone?
Yeah, it is.
So for introducing just like the very basics.
All right.
Is that right?
I'm just
Name the
Calgary.
topic.
So,
Okay, ladies and gentlemen, I think we should begin. This is the CJC Symposium entitled Emerging Themes in Amyloid Heart Disease. A few years ago, Margot Davis and Noel Fine, who are on the podium right now, contacted me to do a position statement on amyloidosis. And I thought, that's interesting. This is a weird little disease. I've seen a few cases of that. And then as we decided to put together a special issue of the journal and this symposium, I realized how important, rapidly growing, and exciting this disease actually was. So I'm really thrilled to be able to co-chair this symposium. And our first speaker will be Diego Delgado, hot off the airplane after a number of delays from Toronto, and he'll be speaking about cardiac amyloidosis and emerging epidemiology and clinical presentation. We're planning on 15-minute presentations, approximately, enough to leave some time for questions, and then we may have some time at the very end for any questions to pose to the panelists. Thank you, Diego.
Thank you very much. I'm a little short of breath, but despite Air Canada, I'm here. Pleasure to share this session with you guys. You've been doing an amazing job in cardiac amyloidosis, so I'm glad that we're all here together. So the idea is to talk about a little bit of the epidemiology and clinical presentation of amyloidosis. These are my disclosures. I've been in the advisory board of the 3 main companies that we're probably going to discuss some of the drugs that are currently available for treatment of this disease. So the challenge of this disease is, as you all know, is usually misdiagnosed. It has a very different natural history and outcomes from any other type of cardiomyopathy that we are used to deal with in our clinics. And as you probably know, are very difficult to not only diagnose, but also to treat. This is amyloidosis. It's a clinical disorder where there is extracellular deposition of this abnormal fibrillar protein that causes destruction of the normal tissue, eventually dysfunction as well. But it's not only the alterations in the structure of the organ that is affected. As you can see here, there are also many other mechanisms that how these proteins can produce damage to any organ, particularly the heart, with different stressors to the cells and different components of the cells, which make the structure of the heart even more difficult to treat eventually. And what we think is important for cardiologists, well, amyloidosis, believe it or not, is one of the most frequent causes of restricted cardiomyopathy in the Western world. For those patients who develop heart disease with severe LV dysfunction, usually the prognosis without treatment is very poor. The median is around 6 months. However, if this disease is recognized earlier, there are specific treatments available that we're going to discuss during the course of this session. So amyloidosis encompasses a group of diseases that you can see here, where mainly the patients who have cardiac involvement usually have what we call the light chain or AL amyloidosis, previously known as primary amyloidosis. And then there is a group of patients who have what we call transthyretin or TTR amyloidosis. And within that, we have two other groups or subgroups, which are the hereditary or mutated and the wild-type amyloidosis. And there are other cases that we're not going to discuss today, which are rare cases, which are AL amyloidosis, previously known as secondary amyloidosis, usually related to chronic diseases. APOA1 amyloidosis is a genetic condition, and then isolated atrium compromise, also another type of amyloidosis. But we're going to discuss mainly those that you see here in the graph. A few words about AL amyloidosis. I think it's very difficult to determine the number of cases, particularly in Canada, but there are some reports in US saying that there are 2,000 to 3,000 cases of AL amyloidosis. There are some reports saying that there is around 5 to 10% of the non-ischemic cardiomyopathies could be patients with AL amyloidosis. And this disease causes about 1 in 1,000 deaths in developed countries. AL amyloidosis, the protein is derived from monoclonal immunoglobulin line changes. There are B-cell dyscrasias where almost 50% of these cases are patients with myeloma, and as you can see here, there are other conditions. Usually patients around the age of 60. In general, they present with multi-organ infiltration and dysfunction. Now, the heart is affected in around 90% of the cases of AL amyloidosis. However, isolated cardiac disease is very rare. It's around 5% of the cases. And unfortunately, these patients died of cardiac death, or around 50% of those patients who have cardiac involvement. So now let's switch to TTR, or transthyretin amyloidosis. If it's confusing as it is, imagine with all the different terminology that we use on a daily basis, it makes things a little more confusing. But basically, we have the TTR and then two types. One is the M for mutated, also known as familiar or hereditary. And then you have the wild type, previously known as senile amyloidosis. This table summarizes some of the characteristics that I already mentioned. In the first column, you see the AL, and then in the second and third column, you see the TTR amyloidosis. The production of the protein is at the liver level. Most of this production comes from the liver in the cases of the TTR amyloidosis. But in the case of the mutated form, is because of a variation in the TTR gene, versus the wild type, which occurs at the liver level as well, but it occurs in elderly people. I will go into more detail later on, but just to show you one of the genetic variations that is commonly seen in Canada is the VAL122L that is commonly seen in the African Caribbean descent population. Unfortunately, this disease is still underdiagnosed. The accurate population, I think, is still very limited, the data that we have. There is some data from many years ago with autopsies showing that around 25% of patients more than the age of 80 could have some deposits of amyloidosis. More recent studies, it shows that up to 13% of patients with heart failure with preserved ejection fraction could have amyloidosis. And also patients going for TAVI, around 16% of these patients could have some degree of amyloidosis. So maybe it's not that rare of a disease. Sorry about these slides, a little bit busy, just to illustrate the different, the epidemiology of the different types. And I would like to point out a few things here. In the first line, you have AL amyloidosis. We discussed about that. And then we have the wild type amyloidosis. The proportion male-female is around 25-50 to 1, usually elderly people more than 60, 70 years old. I want to show you this because here when you see the TTR, the genetic form, we have different genetic mutations, the VAL50, for example, the VAL122 or 144, and the T80. You can see here the prevalence of these diseases or these variations. But it's interesting that regardless of the variation that the patients have, the expression or the phenotype of these patients could be different depending on which country they live, or if they live in the country or they move to a different country. So this is something that is an evolving area, and is something that we are investigating, why some patients express earlier or later, and why there are so many regional differences in these patients. And this again illustrates in the case of TTR hereditary or mutated, a variety of variants that you can see, and then the correlation with the phenotypes of these patients. You can see here that there are patients who have more cardiac expression, others has more neurologic expression, and then you have some variations that eventually have what we call the mixed phenotype with neurologic and cardiac symptoms. Again, a busy slide, but just to illustrate that this is not only a disease that affects the heart, it can affect multiple organs. Again, you have in the first column, you have all the amyloidosis types, and you have the components that can be affected. GI, very common, of course, heart, kidney with nephrotic syndrome, very common, the presentation. And I want to, again, point out here in the second and third line that the wild type, usually these patients don't have autonomic dysfunction, but they have carpal tunnel syndrome, and the variant or hereditary form, these patients could have heart dysfunction, neurologic symptoms or signs, as you can see here. But this is just to illustrate that this disease can affect multiple organs. And the question is how we can identify or help all these signs to identify patients with cardiomyopathy. So these are what we consider, and we are about to publish this, the red flags to identify patients with TTR amyloidosis. So thick hearts, left ventricular hypertrophy, in the absence of severe uncontrolled hypertension is one of the red flags. New onset hypotension as well. Patients who you put them on beta blockers, ACE inhibitors, and develop hypotension, that's another sign. It's very common to see atrial arrhythmias, particularly atrial fibrillation in these patients. I'm sure you'll see many patients in their 70s or 80s who require a pacemaker because an AV node dysfunction, but these patients may have amyloidosis. And the presence of carpal tunnel syndrome, spinal stenosis, is something that usually we don't ask our patients, but this can precede in many years a cardiac infiltration. And then you have the classic signs of right ventricular dysfunction. Again, this is not limited to the heart. You can see here that autonomic dysfunction and gastrointestinal symptoms are very common. And this is why these patients usually have to see 3 or 4, up to 5 physicians before we can reach a final diagnosis. So remember, these patients have heart failure, and the problem is that these patients develop heart failure with preserved ejection fraction and eventually heart failure with depressed and reduced ejection fraction. But we don't need to forget that these patients have an infiltration in the myocardium with very toxic fibers that can eventually produce more damage to the heart. And in addition to that, these patients, they get old, and they have other comorbidities typical of patients with HFpEF, and this is the challenge that we're going to discuss later in terms of how to manage and treat these patients. And of course, the earlier you detect these patients, eventually you could change the course of the disease. A few words about prognosis. The prognosis in the case of the TTR depends a little bit on the fiber type. Usually the variant, so patients with hereditary, has a worse prognosis than the patients who have wild type or senile amyloidosis, and also the specific mutation. There is evidence that the VAL122, the one we see more in Canada, if it's untreated, has a poor prognosis, around 2.5 years, worse than any other type of variants. The age of onset is also important. Patients who start the symptoms earlier, typical from patients with the mutation VAL60, with polyneuropathy, these patients usually do not do well in the short term. And of course, depends on the degree of cardiac involvement. So just to wrap up things, this is not just a cardiac disease. It's a disease can affect multiple organs, and I think all people in the table here were trying for many years to establish multidisciplinary teams to approach the management and treatment of these patients, which, as you can see, is very challenging. In our center at UHN, we have neurologists, gastroenterologists, pathologists, people working with expertise in this field that we work together trying to optimize the management of these patients. So just to finish, in summary, amyloidosis is clearly an under-recognized and potentially fatal cause of heart failure and other cardiovascular diseases. The history and the physical examination, not only cardiovascular, but also extracardiovascular manifestations, can help us and lead to the diagnosis. And if I want to point out a few red flags to remember are the unexplained increase in LV wall thickness, the unexplained sensory motor neuropathy, and dysautonomia, and the bilateral carpal tunnel syndrome, things that we should probably ask to help us to reach the diagnosis of this disease. Thank you for your attention.
Okay, we have time for a few questions. I would ask anyone who has a question to ask to come to the microphone and, if possible, to identify yourself before your question. Diego, a lot of the red flags that you mentioned are fairly non-specific, and we see them quite frequently.
Yep.
So what is the magic piece of information that would lead you towards making a diagnosis or trying to make a diagnosis of amyloidosis? Or would you just give the patient always the benefit of the doubt if there's any signal?
That's a good point. I think as I show you here, these symptoms and signs are not only from amyloidosis. You can see multiple diseases. So I think you have to put things together, you know, the age of the patient, the clinical presentation, evidence from the echo and the ECG, and we will discuss later how to reach the diagnosis. So I think you need to put all these parts together and then eventually, you know, indicate different tests to reach the final diagnosis. But definitely it's a challenge. These are red flags, but definitely with the red flags you cannot conclude that these patients have amyloid. So I think Noel and you will talk about diagnosis and treatments. So I think that's the thing that we need to complement in order to reach a diagnosis of a very challenging disease.
What are the most common other conditions that can mimic amyloidosis, and what would make you tend towards specifically thinking about it?
Yeah. So you have to think about the neurologic symptoms, so any type of polyneuropathy, patients with diabetes or any type of polyneuropathy can mimic the typical diffuse bilateral polyneuropathy in these patients. Any type of gastrointestinal or inflammatory intestinal problems can also mimic the symptoms that these patients have. They may have constipation, diarrhea, and multiple other things. Of course, any type of restricted cardiomyopathy can also mimic what happens in terms of developing of heart failure symptoms. So you need to think of the symptoms and then start going through all the list of potential differential diagnosis. Yeah.
Sure, please.
So what in your clinic, in your sort of heart failure clinics, what are you doing? Do you have a pathway where you identify patients who meet a certain criteria and send them for testing, or are you just kind of gestalting it, and are your colleagues gestalting it, and how variable is that routine?
So a little bit of the structure of our clinic. This year we decided to open, believe it or not, a cardiac TTR amyloid clinic because of the volume of patients. So we are a group of cardiologists who are dedicated to work on this. We have fellows and residents who are here today. So we have an SOP, we have a referral process where we try to optimize the diagnosis prior to the patient being referred to us. And then when the patient comes, we try to finish part of the diagnosis, such as genetics or the PYP that we're going to discuss now, and then offer the different treatment options. But it took us a year or so to establish a multidisciplinary team, very similar to what you established in your centers. Also, collaboration with neurologists and gastroenterologists. So it's really an adventure, but I think we're seeing just the tip of the iceberg, and more referrals are coming. So we need to be aware of this disease and know that there are treatments available now. Thank you.
Thank you. All right. If there are no further questions, then I'll introduce our next speaker, Dr. Noel Fine, my friend and colleague from the University of Calgary. We'll be talking about challenges and strategies in the diagnosis of cardiac amyloidosis.
Okay. Thanks very much. And thanks to Stan and Jennifer for giving us the opportunity to present this session. Thanks everyone for coming. Diego, getting off of a plane that was as polished and poised to talk as ever, so kudos to you. So I'm going to be talking a bit about some of the challenges with diagnosis and some of the challenges with clinical recognition you just heard about, and those carry over into the diagnostic workup of these patients. And so here are my disclosures. The acoustics are terrible. Oh, am I not talking close enough? Sorry. How's that? Okay. So here are my disclosures. The learning objectives. So we'll talk about, clues and red flags and index of suspicion. There may be some of those present on the standard workup for heart failure, and most of these patients present with heart failure. So things that might tweak your index of suspicion just on routine evaluation. Imaging has become really key for the diagnosis and workup, and there are multiple tests available. So we'll talk a little bit about that. And then important when to do biopsy, especially now that we have such advanced imaging options to choose from. So, as you've heard, it can be a challenging disease to recognize. It likes to hide in plain sight. And it can be a challenging disease to work up and diagnose as well. And there's a number of reasons for this. So, it's been regarded as rare. In modern era, we're improving that, but there's been historically low awareness of this condition in many areas. The signs and symptoms are nonspecific, especially early. You heard about that. Also, it can hide in plain sight, but there are variable faces that it can present with. So not all patients with cardiac amyloidosis present the same. Severity can be very mild to very severe. Some manifestations may be more prominent than others, so that's a challenge as well. And then, as I mentioned, there's lots of tests that are available, lots of imaging tests, lots of different areas you could biopsy, lots of laboratory tests. And so how do you weave your way through all of those options to diagnose and recognize your patients in a timely manner as possible? All of these things have led to historically an underdiagnosis, especially of the wild type over time. So here are some clues on standard workup. So if a patient has severe anemia out of keeping with their heart failure, that might be a sign that they have AL amyloidosis with concurrent multiple myeloma, and you can't have both conditions at the same time. Similarly, less common in our heart failure population, hypercalcemia might be a sign that they have AL with multiple myeloma. If they have really severe renal dysfunction, particularly if they have nephrotic range proteinuria. We don't see that a lot with other causes of heart failure. There are some, but that may be a sign that there's AL amyloidosis, and you would see that as well on lipid panel and low albumin. And then the liver panel may or may not show very much, often just signs of passive congestion. Biomarkers, though, are very important, troponin and NT-proBNP. Both tend to be chronically elevated in patients with amyloidosis of both types. For troponin, they tend to be a bit higher for patients who have AL, and that's thought to be because of the direct toxic effects of those light chains within the amyloid fibrils. For NT-proBNP, for both types, they often have very high levels that would be out of proportion or thought to be out of proportion with the clinical severity of their heart failure. Both of these tests are prognostic and, in fact, are used to grade the response to chemotherapy in patients with AL. So those are not to be missed and important tests. So moving on to ECG. ECG can be helpful or it can be rather unhelpful. These are the classic findings that have been reported. So low voltage, particularly in the limb leads, pseudo-infarct pattern, atrial arrhythmias, conduction system disease of all shapes and sizes, and in some patients, ventricular ectopy. You can have all of these, or you can have none of them, which is the challenge. These are all kind of non-specific findings and generally have a low diagnostic accuracy. So if they're there and they point you in the direction of amyloid, great, but they don't certainly rule out if they're not present. I think we've all probably seen patients with unremarkable ECGs, and in fact, many of us have seen patients who have LVH on their ECGs, likely because they've had a long-standing history of hypertension before they developed their amyloidosis. So when amyloidosis is first suspected, and you'll hear this whenever people talk about cardiac amyloidosis, you'll hear this message delivered time and again. Screening for AL amyloidosis in the presence of monoclonal protein is absolutely critical. It's a disease that you do not want to miss. It's rapidly progressive. There's treatments that are available for it. And sometimes it may be obvious that this is what they have, and sometimes it may not be. Screening is generally done by serum and urine protein electrophoresis. as well as serum-free light chain assay. The protein electrophoresis on its own is generally not sufficient to exclude the diagnosis. This is because the light chains are very small and they may not make a band in the gel. And so to increase the sensitivity, we recommend immunofixation. And free light chain assay, this is either kappa or lambda levels elevated in isolation, thus creating an abnormal ratio of the two, either very high or very low, depending on which one is elevated. Couple of important caveats here. So patients who have long-standing renal dysfunction often have elevations in both of these levels and therefore a preserved ratio. So that's something to consider when you get the result back. And as well, there's this entity monoclonal gammopathy of undetermined significance, or MGUS. This is when you have monoclonal protein, but there's no end organ damage or disease that's occurring. It's common in the population and it increases with age. There's also an association recognized with wild type, which may be due to testing bias, because of course these patients are getting this test done more routinely. And so that's also something to keep in mind, is that if there is an abnormal ratio, they may have this condition on top of ATTR as well. And for that, you may need a hematologist to help sort it out. Echo is generally when the suspicion of amyloidosis is first raised, and again, classic findings have been reported. So generally everything looks thick, right? The valves look thick, the ventricles look thick, the interatrial septum looks thick. There's diastolic dysfunction. There may be a small pericardial effusion, biatrial enlargement. Again, most of these are non-specific findings, and you see them with other conditions. So if you add strain analysis by speckle tracking echocardiography, that can increase the specificity of the findings, and the classic pattern is whereby you have reduced global longitudinal strain, but preserved at the apex, causing this base to apical gradient. And just to kind of emphasize my point on some of the challenges, this isn't an imaging talk, but I'm an echo guy too, so just humor me. I'll just let you look at these 3 echoes and tell me which one of them has cardiac amyloidosis. Okay, got a good look. So the answer is none of them. None of them have cardiac amyloidosis. This patient has hypertensive heart disease presented with heart failure. This patient is a dialysis patient who presented with line sepsis. And this patient has hydroxychloroquine-mediated cardiotoxicity of all things. So it just illustrates how it can masquerade and hide in plain sight. So let's play one more time. Who here has cardiac amyloidosis? So now you know I'm being sneaky, so you're not going to volunteer an answer. But the answer here is that all of them do. The first patient has hereditary, the second patient has wild type, and the last patient has AL amyloidosis, but has a completely normal echo, actually. This patient came in with chest pain and volume overload, and after numerous tests, including a cardiac biopsy, was found to have AL amyloidosis. That's not the majority of them, thank goodness, but it just kind of illustrates the point. Cardiac MRI has become a very sensitive and valuable test. Classic findings include a diffuse or subendocardial late gadolinium enhancement pattern. Excuse me. But other patterns may be present, and you need to be mindful of that. Atrial enhancement also is generally a more classic finding. And T1 mapping has really come into the forefront as a modality. Apologies, has really become very valuable for identifying cardiac amyloidosis, both pre-contrast with native T1 mapping and post-contrast with extracellular volume quantification. But again, cardiac MRI does not differentiate subtype. That's an important point, and neither does echo. Nuclear scintigraphy has really come to the forefront and really changed the way we work up cardiac amyloidosis, as it's a very apologies, I'm getting over a cold here. It's a very valuable test and has shown to be very diagnostically accurate. The radiotracer that we use is pyrophosphate. There are other radiotracers that are available, but none in North America. And this can be done either with planar or SPECT. Again, important to exclude AL, because some patients with AL can have mild uptake, and that can throw you down the wrong path into presuming that they don't have AL when in fact they do. So it's always important to screen for monoclonal protein. However, if you've done that and it's negative, then if they have grade 2, which is equal to bone by semi-quantitative assessment or more, or if they have a heart to contralateral lung ratio by region of interest assessment of greater than or equal to 1.5, then that is very accurate for ATTR. And then all you have to do is differentiate wild type from hereditary, which this test does not do, and you need genetic testing for. So who to do a cardiac biopsy on? So with all these imaging tools, it's an important question now. Basically, if the non-invasive testing is equivocal or it's negative, but you have a very high index of suspicion, you should still go on to do a cardiac biopsy. It is the gold standard, and the imaging tests, as good as they are not infallible. Also, AL generally requires a tissue diagnosis to treat, and so oftentimes that can be obtained through bone marrow biopsy, which is generally what the hematology referral will result in, but not necessarily. And so patients may need to go on to get direct organ biopsy to prove that they have amyloidosis to start treatment. There are other kind of less invasive remote sites like FAT-PAD. They tend to have a lower diagnostic yield. I have to say I don't use FAT-PAD biopsy very much anymore because of these modern imaging tests, and also because of its relatively lower yield, and tend to go directly to endomyocardial biopsy if we need it. Once you know that once the tissue is positive for amyloid, then you can send it for subtyping. Mass spec is generally the gold standard. It's available only in a few centers in North America, Toronto and Mayo Clinic, but it can do subtyping quite successfully. Immunohistochemistry is also been reported, although generally not too many labs in Canada really practice this. So in the last minute here, we'll just look at our modern diagnostic algorithm to working up cardiac amyloidosis. So when it's suspected on the basis of standard heart failure workup, echo or MRI, and troponin and BMP, then you screen for plasma cell dyscrasia, as I mentioned. If there's no monoclonal protein present, then you do the nuclear scan, and if that's positive, then you do genetic testing to determine the type. If there is monoclonal protein, then they need a hematology referral, and those patients will generally go on to get some type of tissue biopsy performed. So in summary, my last breaths as I choke these out. Cardiac amyloidosis can be challenging diagnosis with a high index of, and a high index of suspicion is vital. Echo and MRI findings can be highly consistent with amyloid infiltration, but they do not differentiate subtype. Monoclonal protein screening and nuclear scintigraphy are the current diagnostic standards for workup of AL and ATTR. Do a biopsy if those results are equivocal or negative despite a high index of suspicion. You need AL to do you need tissue to treat AL, and do genetic testing if you've diagnosed ATTR. Okay, I'll stop there and collapse, and if anyone has suction, I may need it right now. or questions.
For the nuclear testing, besides pyrophosphate scanning, are there other tests that can be used?
Yes, that's a good question. So there has been some work done with PET scanning, and 18F fluorobatier is one of the tracers that's been used, and that has more sensitivity. It's not widely available, and it's also very expensive. There's also been some work done in MIBG testing to assess autonomic activity of the heart. Of course, we know that this affects the nervous system and the autonomic nervous system, and they can have sympathetic denervation. That's not specific, mind you. A lot of diseases can cause that. And so generally, the nuclear test is the best test. It's also quite cheap. It's becoming more available, and certainly those other tests I just mentioned are probably less available than that one is. Question?
Hello. Hello. My name is Michael Shatreed. I'm a Canadian trainee currently at the Cleveland Clinic. I have a quick question about if you have sort of a tricky situation in which you have low uptake on your PYP scan or your nuclear scan, and then you have an MGUS, but with a negative bone marrow biopsy. Are you comfortable with the PYP, or would you go to endomyocardial biopsy?
Yeah, that's a very good question. So the question was, you kind of have a mild or a borderline PYP scan, but you've done your screening and there's MGUS present. Do bone marrow biopsy, and I think in that case, where there's still question, particularly if the PYP scan is kind of borderline. I would probably go on to do an endomyocardial biopsy in that case, just to be sure. You can be surprised. And often we look at the clinical presentation and think, oh, well, it's kind of slowly progressive as opposed to more rapidly and aggressive that we see in AL. But that doesn't necessarily kind of tell the whole tale. So that's probably a patient that I would do a biopsy on.
Thank you.
David Buick from St. John. No, so I have a patient who's 60, has restrictive cardiomyopathy, severe pulmonary hypertension, and I got involved because she's in right-sided heart failure. Her screening for AL was negative. Genetic screening for TTR was negative, so we did a biopsy of her cardiac biopsy, which initially was reported as negative. So I asked him to send it to Toronto, reviewed by Dr. Bitani, and he's able to scrape out one, quotes, amyloid fibril. And I asked, could they do mass spectrometry, and there wasn't enough tissue. So she had a strongly positive PYP scan. So I wonder, what would your approach be? Very symptomatic, she's on oxygen now and 60. What would your approach be there?
Yeah, that's a tough case, and I'd be curious to hear what the rest of the panel thinks. I think wild-type deposition can occur in the absence of disease. Now, we don't know how prevalent that is, and if you've got one kind of lonely fibril sitting there, is that what's causing this disease? Sounds like the patient you described was fairly sick, and so, that wouldn't kind of be, the moment that the penny dropped for me based on that pathology description. However, I think you found it, and if you can't find any other explanations, we've repeated biopsies in patients because we just have that much of a suspicion and they're that difficult. So that might be something I would suggest, although I don't know if there's really a right answer. What do you three think?
I would say that based on what I heard, you said that you ruled out AL, pyrophosphate was negative, and then you had sort of scant. Oh, it was positive.
Oh, the pyrophosphate was positive. Oh, okay.
Then
Sorry,
I would repeat your
part of the
biopsy.
story.
I would repeat the biopsy then.
Pardon me?
I would repeat the biopsy. If the pyrophosphate was truly positive, like if somebody's looked at the images and the heart looks black on that, then that is very discordant with the biopsy result you're describing. I've actually had a patient who initially was reported as having a negative biopsy, and then they had a positive pyrophosphate scan, so I repeated the biopsy. It was the exact same situation, and that one was positive. They say that biopsy is gold standard, but it's only as good as the person reading it and as good as the sample they get. If it's just papillary muscle or if it's just a chordae that you're looking at under there, you're not going to see anything potentially. So I think I would repeat it in that setting.
Yeah, no, I'd agree. To have a positive scan with very borderline pathology is quite unusual, and usually the pathology would be pretty impressively positive. So it might be worth, if there is doubt, it might be worth repeating the biopsy.
All right. All right, then
Great.
we're
Thank
right
you.
on time. Thank you, Noel. I'm now pleased to introduce Dr. Sarah Cuddy, who is with us from the Brigham and Women's Hospital in Boston. You guys okay over there?
That's like killer.
Dr. Cuddy will be talking to us about recent breakthroughs in the treatment of cardiac amyloidosis.
Okay, thank you very much for the invitation to speak here today. I'll make sure I'm close enough to the microphone. And I'll be talking about recent breakthroughs in the treatment of cardiac amyloidosis. So I'm going to give...
Speak directly to the mic.
Oh, yeah, okay. very close. So I'm going to give a brief overview, very brief since we've had 2 great talks already. I'm going to start by talking about light chain amyloidosis, because with all the kind of excitement over TTR in the last few years, we can't forget about the advancements that have occurred in light chain amyloidosis as well. And then I'm going to present a case which is very, very similar to the gentleman's case, just to give us kind of food for thought at the end if I have time. So, as we know, amyloid infiltration causes a restrictive cardiomyopathy. And just one of the little points that we often make in our echo lab at the Brigham is that not all increase in wall thickness is LVH. So it's very important when we're reporting echoes that we say there's an increase in LV wall thickness, not just LV hypertrophy. So the 2 types that we're talking about the whole time today are transthyretin cardiac amyloidosis and light chain amyloidosis. So different etiologies based on the precursor protein that causes the amyloid fibrils. So we have TTR protein, which is ubiquitous, which breaks down either spontaneously in wild type or in hereditary form due to a genetic mutation. Breaks into its individual monomers, which then aggregate and cause deposition in the myocardium and also in the nervous, peripheral nervous system, autonomic nervous system, and tenos novium. Then we have light chain amyloidosis, which is a plasma cell dyscrasia. So similar, another plasma cell dyscrasia that we always think of as multiple myeloma as well, so along that spectrum. And here we have abnormal light chains, as mentioned before. As mentioned before as well, these also have a toxic effect on the heart, which somewhat is responsible probably for the worst prognosis with light chain amyloidosis, though it's multifactorial. So I can't talk about breakthroughs in treatment without really the breakthrough of bone scintigraphy. It's been around for decades, and even in the 1970s it was recognized as identifying cardiac amyloidosis. But it wasn't really until we distinguished out that it really is specific and sensitive for TTR amyloidosis versus AL that we truly appreciated its value. And now it's really essentially replaced the need for a biopsy in the right setting, and that's with normal SPEP and normal free light chains. And this has brought about our recognition of the increased prevalence, not that the prevalence is increasing, but just our awareness. So as I said, I'm going to talk about light chain amyloidosis therapies first, and I mentioned that it's similar to myeloma, and it's really from the myeloma world that we've adopted most of our therapies. And this is definitely a more systemic disease than we see in the TTR, and here are just some examples. What we talk about is periorbital purpura. Sometimes you want to see these raccoon eyes that are in textbooks, but often this can be very subtle. I just had a patient earlier this week who said she noticed a slight bruising every time she put on eyeliner for about 3 years before there was any suspect of cardiac amyloidosis. Macroglossia is another feature. And then there was mention there of phlebitis PET. So we're using F18 phlebitis PET for research in our centre, and it's led by Dr. Sharmila Darbala. And it's not specific for TTR or AL, but there are some different kind of uptake characteristics between the 2. And here is a patient with light chain amyloidosis, and we can see that this is nearly replacing the need for multiple tissue biopsies. We see really marked uptake in the lungs, in the heart, also in the submammary salivary glands, the tongue and the thyroid gland, and then the liver is just kind of normal background because that's how it's excreted. But what is the thing, why do we keep calling light chain amyloidosis an emergency? As was mentioned earlier, untreated heart failure with light chain amyloidosis historically has a mortality of a median survival less than 6 months. A lot of our prognostic information is based on what's been published from the Mayo Clinic. And then we have to take this in context, though. We have to be careful of these historical controls. So back here, if we kind of focus in on this, this is really based on cardiac involvement. So your staging goes up if you have an elevated NT-proBNP and elevated troponin. So it's really the cardiac involvement that's driving this poor prognosis. But this has been really based on the time when high-dose melphalan and stem cell transplant was the kind of standard of care for light chain amyloidosis. And this has really changed in the last decade. And now we're using proteasome inhibitors, such as bortezomib or Velcade. So this is just unpublished data from our centre compared to the Mayo Clinic data. In the first 50 patients that we treated with the bortezomib regime. And those who were graded as 2 and 3 hadn't even reached their median survival. We had very few patients with a Mayo score 1. But it really is a new era in AL amyloidosis with a markedly improved prognosis over the past decade. There are still those non-responders to the bortezomib-based regimes, and that's where daratumumab, another therapy taken from the world of myeloma, is really revolutionizing care. And we're able to introduce these into those who don't respond initially to Velcade, bortezomib, and also we're starting trials of this given in conjunction with bortezomib. So we're going to see a lot more patients with AL amyloidosis getting into light chain remission and living with amyloid deposition. And just to give a little case example of what we see, so I think most of you might be used to just seeing these polar plots from strain imaging. So we can see that the pre-chemotherapy one, it's just bad. Whenever you see blue on a polar map, it's just not good. And then by achieving light chain remission and getting those light chains right down to normal, we see the patients feel much better, and we see an improvement in their strain over 18 months. So this is just by removing those toxic light chains. But then it also gives us a pause for thought on what happens when these patients are in long-term remission. Does the body itself start to reabsorb the amyloid that's been deposited there when there's no further amyloid deposition occurring? And how will this translate to TTR now that we have therapies available? And that brings me to TTR. So this is the mechanism of pathology. It's formed in the liver and then breaks down, as I mentioned before. So where can we target this? And one of the places we can target is that tetramer, and we can prevent it from breaking down. So stabilizers, and the stabilizing drugs that I'm going to talk today about is tafamidis, which is the only one that's had a phase 3 randomized control trial for cardiac amyloidosis TTR type. Diflunisal has been around for years and is a repurposed NSAID that does have stabilizing properties, but is limited in its use in cardiomyopathy due to fluid retention and renal side effects. And AG10 is another investigative drug which has had very good phase 2 results and is undergoing phase 3 study. So the tafamidis trial was published last year, and what was really notable about this is it was a positive trial in cardiology, which we love to see and hadn't seen such marked positivity in a while, where we see a separation of the curves of 18 months. So those who on tafamidis lived longer and had less hospitalizations than those who were on placebo with ATTR cardiomyopathy. And this is both the hereditary and the wild type. And so not only was there mortality benefit, but there was also benefit to the secondary endpoints, such as 6-minute walk test and Kansas Quality of Life score. I'm saying benefit. These did not improve. The disease was stabilized, or these patients did better compared to those on placebo. It's not that, so it's very important when we're starting patients on this drug, which is now available in the US, we have to counsel them that they probably won't feel better starting tafamidis, that our main aim with this is to help them live longer and stay at a hospital longer, and just prevent the progression of the disease. And this is really relevant given the cost of this, which I might have time to touch on later. Then there was the question raised in this study is, do sicker patients respond poorly? Because we saw an increase in hospitalization in the class 3 patients. The authors suggested that this is probably due to the class 3 patients living longer on tafamidis and hence having more cardiovascular hospitalizations. But it also gives us pause for thought again that this disease therapy needs to be started early, so we need to identify it early. So moving on to production of the TTR protein, previously liver transplantation was the only thing that could be offered, and this is no longer required now that we have these oligonucleotides or gene silencers. So we have 2 available and licensed agents that work as TTR-specific oligonucleotides, inotersen and patisiran. Inotersen is a subcutaneous injection and patisiran is an IV infusion, and both of them really essentially work in the same way, targeting the messenger RNA in the liver to prevent production of the TTR. These were tested only in patients who have the hereditary form of TTR with familial amyloid polyneuropathy. So the main primary outcome of these trials that was looked at was neurological scores. So the neuropathy impairment score and the Norfolk Quality of Life score. So these patients obviously might have had and some of them definitely did have a cardiac overlap, but really it's only been proven in these patients with polyneuropathy. And here we see pretty marked difference between the treatment group and the placebo group. group with progression of disease in those in the placebo group, and same with the quality of life score. And even here in the participant study, there was this signal to possible improvement or improvement in their quality of life scores. So is there possibly regression, or what could be driving this improvement with these gene silencers? So this kind of raises the question is, what works for the nerves might not work as well for the heart. So if we look at the biopsy samples, I think you might be able to appreciate the endomyocardial biopsy, the pink on top, the pale pink is amyloid, or below the green is amyloid. So we see a lot of amyloid in the myocardium when it's there and it's clinically significant, versus what's seen on neural biopsy. You often just see small flicks of amyloid. So it possibly takes a lot less amyloid in neural tissue to cause symptoms, but then there's a lot less in there when therapy is started. So this is kind of just a hypothesis, conjecture about how the mechanism for these medications. Again, this kind of displays how much amyloid needs to be present to cause a restrictive cardiomyopathy usually. But there was, as I said, pre-specified subgroups in the Apollo study and also in the inotersen study. The Apollo study of patisiran kind of had the most exciting data, where they showed a possible decrease in wall thickness, though the standard deviations were large. And there was also some improvement in strain, in global longitudinal strain. But when you kind of delve deeper into the data, you have to kind of take it as it is. It was only the basal strain that improved. The improvement was modest, and it was again best seen in the patients who had the best baseline strain. So these early patients we're seeing where it's most important to start the medication. And these were retrospective reviews. They weren't dedicated cardiomyopathy studies. So this is kind of what we alluded to earlier. This was a patient referred to us a few weeks ago. She was an 80-year-old woman with a history of heart failure, pretty long-standing atrial fibrillation, and they just kind of persistent symptoms. She had a positive PYP scan, which I'll put up. So we see her atria are very dilated. Her history also included mitral valve repair many years before. And there was also the query was, could this be post-surgical restrictive cardiomyopathy as well? And these can be both very hard to distinguish clinically and on echocardiogram. So as I said, her PYP was positive. We did this strain, and those of you who are echo readers, it doesn't have that classical amyloid appearance. It's kind of, there's areas of dark red and light red, but it doesn't have that cherry on top of apical sparing. So we thought that there's likely two pathologies going on here. As well as the TTR, it's probably some kind of long-standing valvular cardiomyopathy, maybe even some restriction post-surgically. And it can be challenging, especially in older women, because older women really don't get significant wild-type TTR on its own. It might be in the setting of another heart disease that we see. It's predominantly men that we see it in. So her copay for tafamidis was $2,600 a month. So are we going to tell this lady, yeah, there's a lot going on with your heart. It could be part of it being TTR, and it possibly is close to $3,000 a month. It won't make you feel better, but it might make you live a bit longer. Maybe, maybe not. So there's no clear answers to this case, so I'm sorry about that. It's just kind of one of these ones that's, like what you said, a bit of food for thought about now that these therapies are available. So just to do a little stop off, sodium restriction is critical at all stages. On the basics, sodium restriction is critical at all stages. Correct atrial arrhythmias, which I think will be spoken about by the next speaker. Echo evaluation is really key at multiple time points. And then just for the diagnosing, PYP isn't sufficient alone, which is a point that we keep hammering home. So if you don't, if you can't treat it if you don't diagnose it, and you can't diagnose it if you don't think of it. So it's one of those doors to think about. So thank you very much for your attention.
Questions for Dr. Cuddy?
I can ask one. So you have tafamidis commercially available, and the payment is an issue for you. In Canada, it's not, so I can just put anybody in the trial I want. Are you putting class 3 patients for the most part on it? Yes,
we are putting. We We are starting class 3 patients on it, yes, but also kind of with that caveat of this lady, we take into context their age, what exactly have they had any previous heart failure admissions or not. If they are class 3 when we see them, but they've had kind of numerous heart failure admissions in the past, then we're a little less likely to put it on. And then actually, I hate to say it, coming from the US, it's hugely dependent on their copay. So if their copay comes back less than $100 a month, we just kind of say, yeah, take it. It's a lot of consideration when the copay comes back at over $1,000 a month.
Yeah, you have a question?
I really enjoy your presentation. I wanted to ask you, what do you do with patients with a mixed phenotype, with heart failure and polyneuropathy, with hereditary or variant TTR? What treatment do you offer? What is your approach in that case?
Yeah, so in that case, we have a few patients. I'm kind of a little bit biased, I suppose, that we're running an open label inotersen study. So we're trying to enroll as many patients as we can into the open label inotersen study. So if we have that, we enroll them in. But at the moment, separate to patients, if they've any exclusion criteria to the trial, we are starting them on the gene silencers. So we're starting patients either on patisiran or inotersen commercially for the combined who have hereditary TTR with any sign of polyneuropathy. We kind of think that potentially the gene silencers may be more effective for the tafamidis just based on that echo data from the Apollo trial. We don't know yet, but if we're seeing some polyneuropathy, we're starting them on it.
So I'll ask you a question. You may not be able to answer this, but for those gene silencer therapies, would you consider diflunisal in addition?
So that's a really good point. Or separate to diflunisal, if we had tafamidis, would we consider both? I think it would be great if we could afford to give them both. That whatever TTR is being produced, we're seeing great drops in the levels, drops from a TTR level of 24 to 8 in the patients that we have on it, or even go down into unrecordable. But for those that still have some residual TTR production, it'd be great to have them on a stabilizer. Diflunisal definitely still has a role. So in those patients that we're seeing that are genotype positive, which is more and more now the 23andMe test for the common TTR mutations. So they test for isoleucine 122, MET30, and ALA60. So patients are just coming to us being like, I got this test in the post. What does it mean for me? And we're kind of saying to them, if there's any hint of early clinical involvement, we're kind of pushing them towards diflunisal.
I have a question. Since, if I understand correctly, none of the treatments that attack ATTR type improve the clinical state. They only prevent it from worsening. That's correct? So how do you know if it's working?
Yeah, so that's also another question we're getting a lot of the time from patients. They're kind of like, I'm on the drug, is it working for me? We're doing TTR levels, so prealbumin levels. What we've seen is in the patients on tafamidis, they actually go up. So we're seeing this little bump. It's not like it goes from normal to abnormally high, but we are seeing a definite bump up that it's stabilized, so there's more TTR in circulation. In the patients on the silencers, we're seeing a really marked decrease in their TTR levels. So we're kind of just having to say, look, this is the surrogate marker. And then we're doing serial scanning. So it's very much the approach we take to the AL patients, where we do serial echo, NT-proBNP, and troponin, and hope that their NT-proBNP stays stable, troponin stays stable, and echo strain parameters stay stable.
Another very elementary question. In terms of standard heart failure type therapies, what works and what doesn't work in amyloidosis?
Yeah, well, beta blockers don't work. I was saying earlier that it's lovely when patients come to see us and you say, oh, stop that metoprolol, and then you call them up a week later and they're like, doctor, I just feel better than I have in years. And it's from something as simple as stopping a metoprolol or whatever beta blocker they've been on. We find that torsemide is much better absorbed. A lot of these patients either have gut edema, gut involvement, dysmotility issues. So changing them from frusemide to torsemide can just make a huge difference in itself, and then being really rigorous about the salt restriction.
I don't think we have torsemide, but we do have bumetanide.
Yeah, which is bumetanide either. Yeah. Thank you.
It's my turn now. I get to introduce Margot Davis from UBC, right? Who's going to talk about, is that right? Okay. Who's going to talk about amyloidosis-associated cardiac arrhythmias and thromboembolism, controversies and approaches.
All right, well, thank you. I'm going to try and talk right into the microphone today because the acoustics are horrifyingly bad in here. I'm excited to talk to you guys about this topic today. It's a little bit different for me. I usually do slides on what you guys have already seen today. And so I had to go a little bit outside my box and explore some controversial topics that there's not a ton of data on. These are my disclosures. These are sort of a number of questions related to arrhythmia, devices, and thromboembolism that I think are maybe not consistently applied across various practices because there aren't a ton of data to inform them. So the controversies that I can think of off the top of my head were, should patients with cardiac amyloidosis receive prophylactic pacemakers? What is the role of CRT in this population? And to that end, what's the role of defibrillators? Is rate or rhythm control a better choice for this population when they have atrial fibrillation? And also, what's the role of catheter ablation in those patients? And finally, what's the role of anticoagulation in cardiac amyloidosis? And so I don't think that in 15 minutes I can address all of these, so I'm going to talk to you today about the ones that are in red. So conduction system disease is very common in patients with cardiac amyloidosis of any type. And furthermore, in hereditary TTR and AL, where there's potentially a lot of autonomic dysfunction, bradycardia can also be mediated by that. Patients with cardiac amyloidosis are typically quite dependent on their heart rate for cardiac output, and so therefore they may be more prone to symptoms with bradycardia. If you think about it, they have these very stiff ventricles with tiny little LV cavities. Their stroke volumes are very small, and so when they become progressively more bradycardic, their cardiac output really drops and they can become very symptomatic. So along with these things in mind, one question that comes up is, should these patients receive prophylactic pacemakers? And what is the role of CRT in patients who do receive devices? So this is some data from a study where they took patients with hereditary TTR who they felt were at high risk of developing to high-grade AV block. There were 100 patients who had either an HV interval of at least 70, an HV interval of at least 55 with a fascicular block, first-degree AV block, or a Wenke-Back anterograde point of less than or equal to 100 beats per minute. So some signs of conduction system disease. And so they implanted pacemakers in these individuals who did not have otherwise an indication for a pacemaker. And over 45 months, 25% of them went on to develop high-grade AV block. And they found that the predictors of those were presence of first-degree AV block just on a surface ECG, a Wenke-Back point of less than 100 beats per minute, so patients with Wenke-Back at rates of 100 beats per minute or more, and absence of low-voltage QRS, which I thought was interesting and sort of difficult to explain. But this sort of raises the question of, should patients we need to be vigilant for signs of high-grade AV block, but should we be more proactive in these patients and think about implanting pacemakers earlier? There are also data that show that conduction system disease is very predictive of outcomes in amyloidosis. This is data from AL. And one thing that was interesting in this study is that they found that the HV interval can be very, very prolonged in patients, even if they have a normal QRS duration. So this can be concealed. You may require EP studies to identify patients who have underlying conduction system disease, but that when patients do have evidence of conduction system disease on invasive EP studies, this is very predictive of both sudden death, which is the black bars on the graph there, or non-sudden death, so progressive heart failure effectively in the gray bars. And you can see that as soon as the HV interval is over 55, the risk of either of those types of death go up quite dramatically. Now, patients who have this conduction system disease also often have abnormalities on signal average ECG, which has been shown to correlate with ventricular tachyarrhythmias. And so some people have said, well, is the sudden death in this population, is it due to ventricular tachyarrhythmias or is it due to bradyarrhythmias? It's important to keep in mind that conduction system disease in patients with cardiac amyloidosis is not isolated conduction system disease. It is a diffuse disease across all aspects of the heart. And so you also have diffuse myocardial disease, potentially leading to abnormalities of depolarization and repolarization and increased risk of ventricular arrhythmias, which of course are observed in this population. So it's not clear necessarily that this conduction system disease is always going to lead to bradyarrhythmic outcomes. It may also lead or identify patients at risk for tachyarrhythmic adverse outcomes. But this study here, I think, is really informative. This was a group of 20 patients, sequentially seen patients who presented with syncope in the setting of AL amyloidosis, and each of them had an implantable loop recorder put in. And they then followed these patients, and over just under a year, 13 of the 20 patients died, and they were actually able to interrogate the loop recorders post-mortem in 8 of those. And I've highlighted the complete AV block. So 6 of those 8 patients had complete AV block as their terminal rhythm, and the other 2 had bradycardia with rates of about 30. In all of these loop recorders that were implanted of amyloid patients with syncope, there was only 1 episode of VT, which was actually in the setting of severe bradycardia, that then spontaneously converted and went back to bradycardia before the patient ultimately died. So it seems that actually high-grade conduction system disease is sort of what happens at the end in all of these patients. But it's not clear. What's not clear is whether putting pacemakers in these patients would change anything. And so you can see that a number of the patients actually did go on to receive pacemakers after developing complete heart block and subsequently died within hours anyways. So I think that based on what we've seen here, these patients are clearly at high risk for conduction system disease, but conduction system disease may just be a marker of bad cardiac amyloidosis. And so while treating these patients with pacemakers, if they are symptomatic and have standard indications for pacemakers in an otherwise generally stable setting, makes sense. Putting these in prophylactically, there's no clear evidence that that's going to help patients. And in patients who have effectively already arrested and are highly unstable and requiring CPR, putting a pacemaker in at that point is probably not going to be effective. Until very recently, there were no data whatsoever to inform the use of CRT in this population. This was a very recent publication. I understand that there are other groups working on similar types of studies out there, but this was just an observational study of patients with cardiac amyloidosis who received pacemakers, and it was not prospective, but they then looked at the patients who had RV pacing and looked at their overall pacing burden, and then separately looked at the patients who had CRT. And you can see that over the follow-up period, there were really quite dramatic changes in the high RV pacing group, in particular compared to the low RV pacing and the CRT group, where you can see that the NT-proBNP started out at 2,500 and went up to almost 20,000 in the patients who were receiving high burdens of RV pacing, whereas those BNP levels or NT-proBNP levels remained relatively stable in the other 2 groups and in fact improved in the CRT group. Now again, this is not prospective data. The patients who were receiving CRT generally had a typical indication for CRT, but it certainly makes one pause when you have a patient who has a pacemaker and is receiving a high burden of RV pacing. It looks like perhaps these patients should be getting upgraded if they're over 40%. So just to summarize that bit, more advanced conduction system disease seems to reflect just more advanced disease in general. And although complete heart block is a pre-terminal rhythm, it's probably unable to be salvaged at that point. It's really unclear whether prophylactic pacemaker implantation will improve outcomes. So for now, it's probably reasonable just to continue to offer pacemakers to patients for standard indications. And we have early data suggesting that RV pacing is detrimental and that patients who are receiving high burdens of RV pacing should be upgraded. And now, these are my own takes from the data. I don't think that any of these are hard and fast, and I would certainly be interested in hearing my co-panelists' thoughts on any of these points. But I'll move on to ventricular arrhythmias, which are also, of course, common, as I've already mentioned. Patients with cardiac amyloidosis are certainly at high risk for sudden cardiac death. The historical wisdom has always been, though, that this sudden cardiac death was due to bradycardia and PEA and that there was no role for defibrillators in these patients. People also said that defibrillators wouldn't work in these patients because of the electrical insulation provided by the amyloid deposits. Having said that, non-sustained VT is often seen on Holter monitors in patients with cardiac amyloidosis. And finally, as a point of background, LV systolic dysfunction tends to be a late finding in patients with cardiac amyloidosis, reflecting advanced disease, and is not clearly associated with an increased risk of ventricular arrhythmias in this population the way it is in our dilated cardiomyopathy patients. So what is the role of defibrillators in cardiac amyloidosis? Well, there have been effectively 4 studies that have looked at this. They've all been done sort of within the last decade or so, but you can see that the sample size of these studies has all been sort of 55 or less. These are small studies. There certainly hasn't been anything like a randomized trial. There are certain centers that believe in defibrillators and they've reported their results, and there are many centers that do not believe in defibrillators and they have not reported their results, and that's kind of how it's worked out. So there's been a lot of bias in the literature to date. But if we look at a couple of these studies in a bit more detail, you can see here that this was one study where they implanted pacemakers in 55 people, amyloid patients of both various types of amyloidosis, and they were implanted either for secondary prevention or for primary prevention. And the primary prevention indications were not your classic guideline-driven indications. These were patients who were listed for transplant, who were experiencing syncope, who had an EF of less than 35%, who had global longitudinal strain of greater than negative 15% or less than 15%, depending how you want to say it, with a pacing indication, or patients who had evidence of high burden of ventricular ectopy on Holter monitoring. And so 27% of patients in this study received appropriate shocks, but 27% of patients in the study also died. And so if you look at I've sort of highlighted, it's obviously a busy slide, but I've highlighted some key points in the study, or in the data there, which is to show you that on the left you have the ICD therapy group, and on the right you have no ICD therapy. And if anything, patients who received ICD therapy tended to be less likely to have advanced heart failure symptoms. They also tended to have higher ejection fraction. So LVEF really doesn't seem to be predictive here, with the average EF in the ICD therapy group being 48% versus only 43% among patients who did not receive appropriate shocks. Global longitudinal strain was predictive, but again, we're seeing that the patients who were receiving shocks actually had better strain values than those who didn't receive shocks. So all of these sort of data points go together to show that patients with more advanced heart failure in the conventional sense aren't necessarily the patients who are benefiting in this amyloidosis setting. I've also just highlighted down in the bottom there the use of beta blockers and amiodarone. Both were relatively low, but you can see there that certainly beta blockers don't seem to be protective against defibrillator shocks. It was a non-significant difference, but more patients in the ICD therapy group were receiving beta blockers than the other group. I'll also just say one last thing here. Predictors of death overall included a higher NYHA class, as you would expect, a lower EF as well, and having AL. So lower EF did not predict shocks, but it predicted death. So EF is predicting non-arrhythmic deaths in this population. Here's another study, very similar findings. What you're seeing there, again, this is again a mix of secondary prevention and primary prevention. The appropriate shocks were received by 32% of patients. The majority of those had AL amyloidosis. None of those patients had had their defibrillators implanted because of an EF of less than 35%. Overall, ICD shocks, the average EF was 54% versus 46% with no defibrillators, and they were much more likely to occur in patients who received the defibrillators for secondary prevention indications. So overall, there are inconsistent results, small studies, publication bias, and so forth, but most appropriate shocks tend to be in secondary prevention patients and those with AL. Low EF does not appear to predict appropriate shocks, but may be associated with an increased risk of non-arrhythmic death, and really we need more data to inform the best use of primary prevention ICDs in this population. And finally, I'm just going to talk briefly about thromboembolism. So stroke and systemic embolism have definitely been reported in patients with cardiac amyloidosis, even in the absence of documented atrial arrhythmias. Amyloid infiltration of the atrium may result in prothrombotic changes in the endocardium, as well as reduced atrial function, sometimes even leading to electromechanical dissociation in the atria and therefore stasis. So what is the role of anticoagulation in cardiac amyloidosis? This here is just a sort of a figure showing what I've just summarized, the sort of Virchow's triad of thrombosis, but you have multiple multiple contributing issues leading to the formation of left atrial thrombus, including the high filling pressures and the low stroke volumes and the overall low flow through the atria. And so this is a study from autopsies and explanted hearts, looking at patients who did and did not have thromboembolism in the heart. And you can see that among patients who in the chart on the left, in the left-hand column, patients who did have thromboembolism or thrombosis in their left atrium, you can see that atrial fibrillation was only in 37% of patients, and 36% of those patients were receiving anticoagulation. You can also see that your traditional CHADS risk factors were relatively uncommon in this group of patients. The average age was only 65, only 17% of patients had hypertension, 7% diabetes, and so forth. Much more common, however, in patients with AL amyloidosis compared to TTR. This is a more recent study that many of you will have seen. This was a study of electrical cardioversions in patients with amyloidosis. And what you can see, the pie charts on the bottom are showing that comparing cardiac amyloidosis patients to control patients also undergoing cardioversion, it was 81% of patients in the amyloidosis group who had their cardioversions canceled. It was because they had intracardiac thrombus, whereas that was only 25% of the control group, whereas the control group were much more likely, if their procedures were canceled, to have it done because they had spontaneously converted. Of those 13 amyloidosis patients who had their cardioversions canceled because of thrombus on TEE, 2 of them had been in atrial fibrillation for less than 48 hours, and 4 had had therapeutic INRs for at least 3 weeks, showing that our typical markers that we rely on to say that we don't need to do TEE prior to cardioversion may not hold in this population. So my summary is longer than my slides. I apologize for that. But I will just say that the risk of stroke, systemic embolism, and left atrial thrombus is not captured by CHADS type scores in this population. And I would advocate that any patient with cardiac amyloidosis with atrial fibrillation or flutter should be anticoagulated therapeutically. This thrombus may be observed in patients with brief episodes of atrial arrhythmia and in the presence of therapeutic anticoagulation. So TE may be advisable prior to cardioversion in a stable patient. And finally, the whole issue of anticoagulating patients in sinus rhythm really needs to be individualized. I know some centers are looking at left atrial function on transthoracic echoes to try and identify the patients in sinus rhythm who might be at highest risk for this, but really this is a point for future research. And so I'm going to end there. I'm just going to thank my co-authors, and you may or may not know that each of our talks today was based on a manuscript that we've submitted to the special issue on amyloidosis in the CJC. And so my co-authors on my paper from which this talk was based are listed here. Thank you.
So while people are coming up to ask questions, I have one or two. The first is rhythm versus rate management in amyloidosis. If the atria are barely contracting, what's the point of trying to restore silent rhythm?
So the rhythm versus rate control issue is a tough one. First of all, I'll say that these patients, once they go into atrial fibrillation, rhythm control is often futile. I think they're more difficult to rhythm control. The other issue is that the rate controlling medications, the typical rate controlling medications, are very poorly tolerated. And just like Sarah said, one of the most rewarding things I do in my amyloidosis clinic is stop people's beta blockers. That's as effective as increasing their diuretics sometimes in terms of making them feel better. I use amiodarone for rate control, and sometimes it converts them, but very rarely. It usually just controls their heart rates. So I think that that you kind of do what you can, but using amiodarone sort of as your go-to medication and not really caring which way it goes is a good approach. I use low doses of amiodarone. The risk of toxicity is quite low at 100 milligrams daily, which is what I'm typically using. This is actually a sort of a study of patients with atrial fibrillation in the setting of cardiac amyloidosis, and this is just a survival curve comparing patients who are on amiodarone to those who were on traditional rate-controlling medications. It's not often that you see a survival curve with even a trend towards improved outcomes with rhythm control versus rate control, but that's what you see here. So that's personally what I do. Yeah. I don't know if anybody else has anything to add to that, though.
Yeah, we definitely use an amiodarone. We do not refer these patients for ablation, and often that's when it's sometimes that's how it's picked up, as they've had multiple ablations and still poorly controlled AFib. But we do give them the benefit of a doubt and try and cardiovert them. Often they've come in atrial fibrillation because they're blatantly fluid overloaded, so we diurese, and once they're diuresed, they can maintain sinus rhythm. And even maintaining sinus rhythm for a few months extra can just be a big advantage quality life-wise to these patients.
There's a question, a couple of questions from the audience.
Excellent presentations from all. I learned a lot.
Can you speak up a little louder,
yes,
John?
Excellent presentations from all. I learned a lot. A number of things popped up. One, why are women protected from, particularly from the wild type form? Two, you didn't talk about small vessel deposition of amyloid protein and the increased risk of intracerebral hemorrhage, and you discuss that when you talk about the relative risks and benefits of anticoagulation or not. And number three, when you do put a pacemaker in, do you use methods such as an echo-guided protocol to look at the optimum rate to maximize cardiac output in these individuals?
So I couldn't hear your first question. I can offer my input to the other two questions.
Why are women protected, particularly with respect to the wild type? I saw a ratio of 25 to 1.
Women are protected.
Why are women protected? Is that the question? I don't think anybody knows that. I certainly don't.
No, one of the real issues is making animal models. So it's very hard to make an animal model of cardiac amyloidosis. There's been some success with mouse models, zebrafish, but nothing reliable. So it's one of the big areas of research in the field, is making a reliable animal model to understand the sex differences.
I would add, I think there's definitely a major male predominance for wild type, but as a result of, I mean, I have patients with wild type who are female. And I think we have to be careful not to kind of cross that diagnosis off the list in some patients. As to the mechanism, I don't have an answer for that either.
And the second question related to intracerebral hemorrhage from amyloid deposition in small arteries and arterioles. Wasn't discussed.
So there are some of the more rare mutations that are associated with that more than others. Other than that, the sort of typical amyloid angiopathy of the brain is, it's a different type of amyloid. It's a different precursor protein. And although it may coexist because this is an elderly population in wild type, it's not, the incidence of it is not increased in this population to my knowledge. And so it's the same risk that you would have in any 85-year-old who you're anticoagulating. I mean, the vast majority of these patients do develop atrial fibrillation, and so most of them are on anticoagulation. And I've had, I wouldn't say more frequent problems with intracranial bleeding in my amyloid patients compared to my other heart failure patients with AFib. Does anybody have anything?
I think, John, once the disease is advanced, there are studies showing biopsies that infiltration of the vasculature as well as any type of organ. So it's common to see in advanced diseases, particularly in the AL amyloidosis, where it's more prevalent to see those findings.
And then do you have a protocol to determine the optimum rate to give you the best cardiac output in your patients?
I personally don't, but I always ask them to pace them at least 70 as their lower rate limit. I don't know what you guys do.
No, we just really go for a CRT approach. So we really ask that a CRT device is put in. And we're actually conducting a study at the moment to see if there's an optimal rate to set this at, but we don't have any definitive results yet.
Hello, thank you for the great presentation. I'm a cardiologist from Quebec. I have two questions regarding anticoagulation. First is the risk of stroke in patients with atrial dysfunction. So I have a patient I follow at the clinic. So he has AL amyloidosis, and once I I saw his EKG, there was no P wave. I look at his echo, there was no A wave, and I thought he was in atrial fibrillation, so I put him on the anticoagulation. But then after that, he came for a syncope, and he had a pacemaker put in, and when the pacemaker was interrogated, there was no AF. So I just realized that he had atrial dysfunction, that's why we didn't see the P waves. So I decided to stop the anticoagulation. So I wanted to know what you think about the risk of stroke in this kind of patient. And just a second question. So if I do want to anticoagulate, do you have a preference for warfarin versus NOAC in this population?
Yeah, so I'll step in. We routinely enough will look at atrial function, and regardless of the rhythm, if there's no discernible A wave, we'll have a pretty low threshold for starting the patient on anticoagulation. So I wouldn't kind of use it as a blanket approach, but we definitely have a very low threshold if we see really poor atrial function on echocardiogram for starting anticoagulation despite an absence of atrial fibrillation or an atrial arrhythmia. And that's kind of been proven out. There is some case reports and small data that patients have embolic events while in sinus rhythm.
And I agree with that completely. And I would also say that AL patients are clearly at higher risk than compared to ATTR. So if you have an AL patient with no A waves on their echo, I think it would be very reasonable to anticoagulate that patient. The other thing to keep in mind, though, is that AL patients do often improve with therapy. So if the patient's actively being treated with chemotherapy right now, just make sure you follow up on that, because you may see some restoration of atrial function as time goes on. Your other question was warfarin versus DOAC effectively, and I personally use DOACs in my patients unless I can't for whatever reason, but I don't think that there are obviously no data to support one approach or the other, but I haven't had any bad outcomes that way.
Thank you so much.
I just wanted to clarify something. I see a large group of patients with AL amyloid for many years because of our proximity with PMH, Princess Mary Hospital. And the reality is these patients, as you mentioned, they have usually very advanced disease, renal failure, gastrointestinal involvement with AL amyloid. So usually these patients have a significant tendency of bleeding. And I don't remember, really probably a handful of cases that I initiated anticoagulation. Usually it's just, we don't put them on anything, or we have the discussion with the oncologist, even though their CHAD score could be high. Usually we don't initiate because of the potential side effects on these patients. So it's not that it's systematically in our center we put them on anticoagulation. We really assess every individual case, and occasionally we initiate anticoagulation.
I have actually, do we have time for one more question? Sure. I have a question actually for the three of you. So in a similar vein, a lot of the wild type patients who get referred to me, they've already been put on a beta blocker sometime in the past for some reason. Most of the time they're older, they have multiple medical problems. Do you routinely stop the beta blocker as soon as you meet them, or by way of protocol essentially, or do you use a different, more tailored approach? Margot?
I routinely stop their beta blocker.
It all depends. As the disease advances, probably this patient will not be able to tolerate it, so I will be more inclined to withdraw. With the initiation of the new drugs like inotersen and patisiran, these patients cannot be on calcium channel blockers or digoxin, so that's something that systematically we stop before starting treatment. Beta blockers, it all depends on the case, but
yeah, we would go for quite a kind of a broad approach of going with discontinuing it unless there's some real issue with the rate-controlled AFib, where we try and keep them on as low a dose as possible, but otherwise we'd stop it universally.
I don't think there's a right answer. I think over time I've gone with a more tailored approach. I have been burned at some times, been stopping patients, and they've ended up in the emergency department that weekend with, that's the minority, but with rapid AFib and heart failure. So I think we need to learn more. It's just interesting to hear.
Yeah, we actually do a really, really slow taper.
I'll cut it in half, and then I'll do a holter and see what the rate control's like. And as their rates start to creep up to 100, their average rates start to creep up to 100, that might be when I introduce amiodarone and make the switch.
I have a kind of pedestrian question, and that is, do you think every tertiary care hospital should have an amyloidosis clinic, A? And And B, these patients are pretty common, but could benefit from specialized care. At what point should the community hospital or community cardiologist refer someone to a tertiary care center for amyloidosis, at least consultation, if not management?
I think there's a real benefit for a lot of these patients to be managed by a sort of multidisciplinary team, and so for that reason, I think that there is a value, even though it may still be a small population, whether that's an official clinic or a virtual clinic, but to have somebody who has an interest from a cardiology side, from a neurology side, and from a hematology side, and then maybe a nephrologist and a gastroenterologist as well. But I think those three specialties are if you can have somebody in each tertiary care center who is identified as the amyloid person to go to, that's probably enough. Does every community hospital need that? Probably not, but I think that there is value in those patients, if it's reasonable to travel, to be seen in a center with some expertise where they may have access to clinical trials, where there might just be things that are thought about or that you have access to that you don't have in the smaller centers. I know in BC I see patients from all over the province, and some of them I see once and then I hand off to their local internist, and some of them I'll see them once a year or to telehealth visits, but I do think that there is some value there. I usually find that I'm doing something a little bit different.
I agree. I think the hospitals and centers in the community has an essential role in identifying these patients, initiate the workup, and then refer to the centers that Margot was referring to. I don't think that moving forward, anybody should be prescribing all these medications. It should be done by people with expertise in the field. Maybe down the road, everybody will be more comfortable, but I think there are so many new drugs and that had to be done and managed by someone with expertise in the field at this point.
Okay. Margot, you said that you said there's a small number of these patients. You think it's really a small number, or you think we're missing a ton of them?
I know, I don't think it's actually a small number, but I mean, it's hard to support the establishment of a clinic in every hospital right now based on the number of recognized patients, but yeah, your point is well taken. This is probably a relatively common disease in the elderly population.
Yes. Speak up, please.
In Canada, can I get some sort of idea how many patients are actually being treated for amyloid? I mean, we've talked about the diagnosis, we've talked about the suspicion. How many are actually getting to the point of being treated?
We need a registry to inform that. I don't think anybody. So we are putting together a Canadian registry because we're trying to understand questions just like that. I think that probably the three centers represented up here have the highest single center populations of patients being treated for amyloidosis across the country. If you include AL, you'd have to ask the hematologists as well, but I know I have about 150 patients in my practice. I'm not sure, and so that could,
Is your question about the novel therapies or just the prevalence?
Novel therapies, I think.
Yeah.
Oh, novel therapies specifically?
Yeah, once the diagnosis is made, how many patients are actually progressing to treatment?
Are you talking about the TTRs being treated with tafamidis, or are you talking about having their beta blockers stopped?
Well, we're talking, that's the one treatment that we have available, and the other drugs are in the process of being researched.
Oh, so for
how many are
tafamidis in
actually
Canada?
getting treated once you make the diagnosis?
So right now, tafamidis is only available through an open-label extension of the clinical trial, and it's only being run in 3 centers in Canada right now. And so we could do a quick tally. I think there's probably about 100 patients across Canada.
So for this relatively frequent diagnosis, we're not actually getting to the treatment stage all that frequently in Canada at the current time.
Not yet, partly because it's not, it's underdiagnosed, but partly because the access to it's not commercially available in Canada at this point.
How does that, just for curiosity, how does that compare with what you would do at the you're at the Brigham?
Yeah. So let's say tafamidis has been available to us commercially since the summer. So we already have about 80 patients that we've prescribed the medication, whether they're willing to pay the copay in some instances. But yeah, we're kind of, like I said, prescribing it to nearly all our cardiac patients, with wild type, that is. So again, it's really hard to tell this as a prevalence thing because we're such a centre, like a quaternary referral centre nearly. So it's very hard to get a kind of general population idea on it. But it's definitely, I think, already being shown that it's being prescribed more than was predicted initially, anyway.
Any other questions? So do you anticipate quickly, do you anticipate that, say, 5 or 10 years from now, we'll be using a lot more tafamidis and other, maybe the siRNA molecules?
Yeah, I think so. I think we're just at the tip of the iceberg as far as disease-modifying therapy. There are competitors for tafamidis that are being researched right now, and next-generation gene silencers, and so you know, especially in Canada, it's very early days, and what the future will look like and how many of these patients will have access will really come down to cost, and so. I think 5 years, things are going to look very different, I hope.
What is the current cost of tafamidis?
So there is no cost in Canada yet, but in the US it's $225,000 per
How
year.
much?
$250,000.
$250,000
So if you're
a
paying
year.
out of pocket, you're $25,000 a month. You've one patient.
But as the competition moves in, presumably the price will go down considerably.
Yeah, and it's still priced as a rare disease drug. And I think that as the prevalence is, if what we were predicting the prevalence is actually comes to light, then that will change the formula, I hope.
Okay, well, I would like to warmly thank all the members of the panel for their wonderful presentations and the audience for their attention. Thank you very much.